Hello and welcome. My name is Lauren Scholler. I'm one of the Education and Information Board members for Miles4Hips. I'm joined by Dr. Eduardo Novais, an orthopedic surgeon at Boston Children's Hospital, with their child and young adult hip preservation program. Dr. Novais is an expert in hip preservation and reconstruction and in the care of patients with hip dysplasia. So, Dr. Novais, thank you so much for joining us today.
Of course, it's a pleasure.
Awesome. To start, we would love to hear about your path to medicine and what made you interested in orthopedics and particularly hip preservation and reconstruction.
Well, let me see. So I'm from Brazil originally. I grew up playing soccer, played a lot of soccer when I was young, and also did a Brazilian cultural fight or art called capoeira. And I had my own injuries, and I was always interested about the recovery process from when you get an injury and when you get back. So when I was in medical school, it made a lot of sense for me to be involved in something related to the musculoskeletal system. But I found a passion for pediatrics too. So at that time, as a medical student, I didn't know that pediatric orthopedics was something that existed. So I got more mature during the medical school, and I fell in love in orthopedics, and then I decided to pursue orthopedics, and that's when I was actually introduced to the concept of pediatric orthopedics. And after my first 3-month rotation as a PGY2, I knew that was what I wanted to do. So very early on my second year to my third year, I made that decision, and then I decided to do a pediatric orthopedic fellowship, and I did that in Brazil. But then I decided to travel to the US. I did a traveling fellowship. Then I went back to my country where I practiced pediatric orthopedics for a while. And I always had a passion for the hip, mostly because of developmental dysplasia of the hip in babies and infants and children. I thought that the surgery for an open reduction of the hip was the most, and I think and I still think is the most fascinating surgery that an orthopedic surgeon can do. So while I was in practice in Brazil, I had some offers to come back to the US, and then I got married. We came back to the United States. I did another fellowship in pediatric orthopedics at the University of Utah. Then I did a fellowship in musculoskeletal oncology at the Mayo Clinic. And then I did the Boston Children's Hip Preservation Fellowship. And then I got my first job in the US, which was a director of hip preservation at Children's Hospital, Colorado. And I was in Denver for 4.5 years. And then in 2015, I moved back to Boston, and I'm currently there as an attending surgeon at the Hip Preservation Center.
Well, that's great. So what is hip preservation and reconstruction, and what's a unique aspect about this subspecialty?
So hip preservation is any type of intervention that has as the end goal to preserve the patient's native hip. So a number of pediatric conditions like slip capital femoral epiphysis, Perthes disease, hip dysplasia, some trauma and infection can lead to deformity of the hip joint that is associated in the long term with hip osteoarthritis. And the ultimate treatment for that when you're an adult or an older adult is a total hip replacement. So hip preservation is a large umbrella that encompasses any type of intervention, surgical or non-surgical, that wants to preserve the hip joint, the native hip joint, without the need for a total hip replacement.
Okay, and would you say that this is a new and emerging field in recent years?
So the thought of hip preservation surgery, it's not necessarily new. You know, hip surgery to improve the shape of the hip joint has been done for a long time. But it was not until late 80s and 90s and early 2000s that the concept of hip instability and femoroacetabular impingement became more popular through the work of Professor Ganz in Switzerland. So after some of the papers that he published, which were landmark papers, the world got interested in this concept of joint degeneration because of shear stresses associated with instability, or because of cartilage degeneration associated with impingement. And then after that, initial work in Switzerland, there's a lot of different centers in the world developing different techniques and developing and advancing the field of hip preservation. To the point that now a lot of the procedures can be done arthroscopically. Some of the procedures still need to be done through an open surgery. But it's a fascinating field that is still growing compared to other areas of orthopedics like total hip replacement and total joint replacement, for instance.
That's great. That's really interesting. In your practice at Boston Children's, where you treat patients in infancy, childhood, adolescence, through young adulthood, how do interventions for hip dysplasia change depending on the age of your patients?
Yeah, so that's a great question. This is one of the things that I am fascinated about my practice. I can have in clinic a newborn, like yesterday, for instance, I had a 7-day-old baby with a family that were very anxious because the hip was found to be dislocated at birth. And then I saw that patient. Of course, at this early stage, there are treatments that don't involve surgery. We use brace treatment. The most commonly used is called the pelvic harness. So then I finished the visit with that patient. The nurse came, put a harness. I checked the harness and spent a lot of time with that family. And then my next patient was a 24-year-old Division I ice hockey player that has hip dysplasia. So, then the conversation is very different because we have to talk about his sports participation, his limitations because of pain, his goals, and discuss about a surgical reconstruction to allow him to go back and play.
Very interesting. When you, in terms of treatments for hip dysplasia, one of them is a periacetabular osteotomy, otherwise known as a PAO. Can you go into more detail about what a PAO is?
Yeah, so first, an osteotomy means a cut through the bone. And a periacetabular osteotomy, peri means around. Acetabulum is the hip socket. So it's a series of cuts through the pelvic bone around the hip socket. So this is a surgery that was developed in Switzerland in the late 80s. The first ever published paper was 1988. And it's been around for quite a while. And through this procedure, which is done these days with a relatively small incision, like a 10-centimeter incision in the front of the hip, we can cut the 4 main bones around the hip socket. And then we call it that the hip socket fragment is free. And then with that, we can rotate the fragment of the hip socket in the direction that we want to improve the coverage of the femoral head. Because the problem with hip dysplasia is that the femoral head is not well covered. So through the surgery, the periacetabular osteotomy, we can increase the surgery most of the time to normal coverage. And if we achieve normal coverage, we expect to restore the mechanics of the joint. And if we restore the mechanics of the joint in the presence of healthy cartilage, then we expect that the hip will have a long-term survival. So the PAO is one of the surgeries that I most commonly do. And it is a procedure that is commonly done for hip dysplasia these days.
What patients are typically good candidates for a PAO?
Well, so that's a good question. Typically, originally it was described for patients that were skeletally mature, which we defined by closure of a cartilage in the pelvis called the trier cartilage. But we have been pushing a little bit the envelope and doing surgery in some patients that are a little younger than that, but typically patients that have stopped the growth of the pelvis as a minimal age. As far as age, as the maximum age, what really matters is the quality of the cartilage. We are publishing a study this month. Hopefully it's under the last round of revisions, where we looked at patients that were older than 40. And what we found in that study is that it's not the age that is the main determinant of how the patients do. It's actually the quality of the cartilage. So it's the physiology of the cartilage that determines the PAO as far as it should be done to preserve the hip or not in an older patient. And of course, those are good prerequisites, that the cartilage should be good, the joint space should be preserved, but also the function of the hip should be preserved, that the hip has to move in an appropriate way. And we have ways of establishing that through functional radiographs, but we also have advanced imaging to look at the hip and assess, is the hip unstable enough to do a periacetabular osteotomy? Does the hip has uncoverage in a specific area that we have to cover during surgery? So here we have an ultrasound technique that was developed by our colleagues, Dr. Pierre Democourt and Andrea Streccolini, to look at instability of the joint, and all the other folks in the sports medicine division. And we also have something called a virtual hip, which is a software that we use to analyze the three-dimensional coverage and impingement of the hip, which was developed by our colleague Ata Kiapur at the biomechanics lab.
Oh, wow, that's really cool. Since you see patients along the continuum of care, starting at initial diagnosis of hip dysplasia and discussing surgery and preparing for surgery, what can you share about how patients can best prepare for a PAO?
Oh, so that is an excellent question. We always talk about with patients that the PAO is a journey, is a long recovery process. It's a relatively invasive procedure when you're talking to somebody that you're going to cut the pelvis in 4 areas. Although we can do that very safely, the rate of complications with that surgery has dropped significantly. And we were very honored to publish our papers in our first 40 patients, both myself and Dr. Woody Sanker from the Children's Hospital of Philadelphia. And we showed that being well trained in the center facilitates lower complications. So we can do the surgery safely through a relatively small incision. But the surgery requires a lot of dedication for the patient, from the patient perspective. So I tell patients that the patients should be in their best possible state of health. And I would include that mental health, physical health. Of course, the patient has pain, but it is important for the patient to have some strength and stability in the gluteal and the core musculature to allow for rapid recovery. So mental health, physical health, and social health is also important for the patient to undergo the surgery. So I always counsel people that it's a logistic project that you're going to go under. You're going to need some help from parents or very close partners or a very close friend that can live with you for about 1 or 2 weeks to help you cope with the first 2 weeks. You're going to need to use crutches for about 8 weeks or so. You're going to do a lot of physical therapy after surgery. And in a lot of instances, I have been doing something called a prehab, which is we meet with the patient and say, hey, listen, we know that the surgery will work for you and help you, but it would probably be better if you go to physical therapy and develop some strength, some stability of the muscles in order to recover faster and better from the surgery. And then I also go with the patients and tell them that it's typically a 2 or 3 hour procedure. Patients stay in the hospital for about 2 nights. The patients have a catheter in the back that helps with the amount of medication that they need to take. We're very conscious that we want to avoid as much as possible narcotics for these patients. So we do have a catheter displaced by the anesthesiologist and the pain team in Boston. And we start physical therapy the first day. And then we do physical therapy for teaching the patient how to use crutches and how to do stairs. They go home and we check them about 3 weeks. And at that visit, we look at an x-ray, and most often we start physical therapy at that time. And then we revisit with them at about 8 weeks to look at the healing, to see if there's enough healing to allow them to discontinue the crutches and to test the stability to see if they can discontinue the crutches. And after that, we meet with them in 2 months or so to see how the progress is doing. And typically around 6 months, if the patient does athletics, they can start to go back to practice and do some athletics. But it's not until about average of 8 to 9 months that the patient can be fully returned to athletic activities.
Okay, yeah, I think those are all really important points. And I think some of it really touches on your philosophy of care and how involved you are with your patients. So thank you for sharing a lot of that. My next question was going to be, what does recovery typically look like? Which I think you just explained a lot of that pretty well. But is there anything else that you wanted to add? And what outcomes can patients generally expect after a PAO?
So typically a patient can expect that the pain will be improved. Like, if we can make a case that a patient is experiencing pain and there is clear evidence on x-rays and advanced imaging like ultrasound, MRI, or CAT scan or whatnot, that there is dysplasia, and we can make an association between the pain and dysplasia. And sometimes there is a labral pathology too, or chondropathology that can be treated with arthroscopy. But if we can make that association, then I can tell a patient, your pain will improve. It's hard to tell a patient how much they're going to improve, but we have evidence that more than 88% of the patients meet what's called the minimal clinical improvement with the surgery. So that's one point. So then they can get encouraged to prepare themselves for the surgery. And then the other thing I tell them is that it's a long recovery, right? Until you are able to simply go grocery shopping on your own, walking around, the parking lot to go grab a shopping cart and go around and the supermarket and finish your grocery shopping. You probably will need like 4 months or so to be able to do that, maybe 3 months. So it's a long recovery. So I educate the patients that there is a little bit of a roller coaster during the PAO recovery. I always tell patients there are going to be some days you're going to wake up and you're going to ask yourself, why the heck did I do this? And then I just tell them that this is not just one day. You move on, and there will be some days that you're going to feel like so great that you're probably going to test yourself and go for a longer walk. And then you're going to wake up the next day with a little more pain than you have before. And you say, why the heck did I do that? So I explain to the patients that it's a process. There's a little bit of up and downs, but the goal is to say, okay, 2 weeks ago, I was not doing as much as I'm doing there. So we measure the progress in about a week or 2 week basis. So as long as you're making progress, that's what we expect. And we check with the patients. I explained to you, like, what is our typical protocol, having that in mind. We don't let patients go without seeing us more than 6 to 8 weeks for the first 4 months to help them and encourage them. And at some point, we're the patient's greatest cheerleader because, they need support and they need to understand that their recovery is going within what we expect.
Yeah, definitely. I think that's really important to set patient expectations going into it. And I think you do a really excellent job at that. That helps with the recovery process because we know that that process isn't linear. And so there are a lot of factors that go into that. What are important qualities and factors that patients should look for in a PAO surgeon?
That's also a great question. In the past, in the very past, there used to be a list in a website of who are well trained enough to do a PAO surgery. I don't think that exists any longer. I also think that there are currently a couple of different training centers that are training patients. For instance, we do have a hip preservation fellowship where we take one individual that has finished residency, has finished one fellowship either in sports medicine or pediatrics. They want to do 1 year dedicated to hip preservation surgery. And there are other centers too that have dedicated fellowships for this type of field of practice of orthopedics. So it's important to understand the background of your surgeon. Was the surgeon trained in a large center? So the importance of being trained in a large center is actually proven in that manuscript that I published with Dr. Senker from the Children's Hospital of Philadelphia, where we showed that our first 40 PAOs for each one of us, our rate of complications was the same as the masters that taught us. We did have a little more blood loss initially in our first 40 cases, but there was no more incidence or occurrence of major complication. So the message from that is that during our fellowship, we were exposed very gradually and we matured at that time with that surgery. So we were ready to go ahead in our practice and start doing that procedure. So investigate the educational background, if you will, of your surgeon. Also discuss with the surgeon how many procedures they do a year. PAO surgery is such a complex procedure from a perspective of a system that the surgeon should be doing a fair amount of surgeries a year. I don't know if there is a magic number, but I like to think that we have about 52 weeks a year. And if you're doing one PAO every other week, your volume will be somewhere around 25 PAOs a year or something like that. So that, I think, is enough to keep somebody very sharp in the surgery. And of course, in the large centers like here at Boston, HSS, the Washington University in St. Louis, in these large centers, there are more than 150 PAOs done a year. So this is something to consider when you're thinking about where do I do my surgery.
Okay, and kind of going along with that, what do you think is important for patients to know when they're undergoing a PAO?
I think we covered some of that. They need to know what they're signing up for, right? They need to know about what is your surgeon plan for the inpatient recovery, how they're going to manage your pain, how are they going to manage your post-operative visits, who is your contact person. It is very important that, sometimes surgeons forget, but we are human and we need to have a team that helps us help our patients. So in my practice, I do have a dedicated nurse, her name is Christine, and a dedicated nurse practitioner, her name is Ariana, who helps me with every patient that I have. So if I'm scrubbing the OR, they are always available to answer questions, answer emails. So you need to talk to your surgeon who's going to help me if I need something. Also, what is your protocol for recovery? We give patients the protocol for physical therapy when we discuss surgery, so they can bring to the therapist and say, hey, this is what I'm signing up for. And then if the therapist is not comfortable with PAO recovery, they can find a place close to their home that they can do the physical therapy. I think that another key point to discuss with a surgeon in preparation is what to expect as far as my school or my job. And I think surgeons vary a little bit, but you will miss a little bit of school. And you definitely, if you're working and you're on your feet most of the time, you're going to miss some of your job. So we have to help the patients with that as well. And also, I think that we need to discuss with the surgeon exactly how do you envision the surgery going? What is your goal for correction? Are you going to need to look into the joint? Are you going to need to do anything to the labrum? Do I have impingement associated with PAO that needs to be corrected during the surgery? How is my femur looking? Do I have excessive version, which is torsion of the femur? Do I have not enough version? So with all of those things in mind, then you have a good plan for the surgery, a good plan for early recovery, and a good plan for long recovery with enough support from the team. So then it's like you probably sign up for a successful process. I wouldn't go into a PAO surgery if I didn't understand all these details. And it's important to spend time with the surgeon and the team and have all your questions answered. Because, when the surgery is done, it's done. I had an assistant that used to make a joke and tell me, Dr. Novais, you cannot unsurgerize somebody, and that is something that stuck with me for a long time, until today, that, when surgery is done, it's done. So it's a very unique opportunity to have all the pathology try to be corrected during the procedure. We need to discuss that with your surgeon.
Yeah, I think those are all such great insights around kind of the team approach and what to really look out for when you are going into a PAO. But this has been really great to hear so many of your perspectives and just your passion and dedication for what you do. And I just wanted to ask one last question, which is what excites you about the future of hip preservation and reconstruction, and where do you see the field going and any advancements to look forward to?
I think this field is young. And I think there are major changes in the way that we understand how the hip functions. So one of the things that's very exciting is, as I explained to you before, that is we have the ability to investigate a hip with three-dimensional imaging and determine exactly where the hip lacks coverage, where the hip has excessive coverage or excessive bony impingement. And then we can design a treatment that's very specific for the patient. I think the next goal will be in the future to have that in the operating room, some sort of guidance through image, maybe some robotics to help a PAO be less of a surgery that depends on the surgeon's subjective analysis. But if you have like imaging, like a CAT scan during the surgery guided by advanced imaging and robotics, maybe we can make the procedure more standardized. That is super exciting. I think the other thing that is super exciting is where the field is going as far as cartilage restoration. To this day, related to hip dysplasia, that's not as much of an issue, but related to impingement, a lot of times patients lose cartilage in the femoral head and in the socket. And I am very excited about cartilage restoration in the hip. It's some of the areas that I study, that I practice, and I'm getting involved in some of the research. So I think that in the future, we'll be able to look at a hip that, currently will say, maybe this is better with a total hip replacement. But hopefully in the future, we'll have technology to work with cartilage restoration techniques to say, no, we can restore this cartilage. And then you do a procedure to realign the joint and achieve a long-term preservation of the joint that way. So I think these two things are exciting. And then last piece is that the patient engagement portion. I think that there are multiple procedures in orthopedics that are very well accepted, very well standard. Like if you talk to your grandma community and somebody in your grandma community says, oh, I'm going to see my surgeon because I need to have my hip or my knee replaced. Nobody's going to say, what? But if you tell your friends at college or medical school or whatever your field of friendships is, if you tell your peers, I'm going to see my surgeon because he needs to cut my pelvis in 4 places and rotate and put screws around because I have hip dysplasia, people would say, what? Isn't that a dog thing? So the patient engagement and things like your community is doing and getting education is essential for the field to grow with eyes into the perspective of the patient and taking the patient community as a into consideration. So these things are very exciting to see, and I can't wait to see what the next 15 or 20 years of my career are going to look like.
That is exciting for sure. And not only from a healthcare provider standpoint, but as you mentioned, from the patient perspective, I think it's really neat to think about how the future of hip dysplasia will look like for those experiencing hip dysplasia and what their care could look like and how that could change. So, and I think a lot of this is in part thanks to research, which I know that you and your colleagues at Boston Children's are highly involved in. So it's really great to hear about all of that and the exciting things to look forward to in the future of hip dysplasia care. So it's been a true pleasure talking with you today, and I know that many people are going to enjoy getting to know you through this discussion, and we'll learn from your valuable expertise and insights surrounding hip dysplasia. So we're so grateful for the difference that you're making in the hip dysplasia community, and thank you for taking the time for this wonderful conversation.
No, thank you for bringing me in here. It's a pleasure to spend some time with you. And I hope that, if this conversation reaches one single person out there and makes a difference in them getting educated about their issue, I think we did our goal.
Awesome. I love that. Thank you, Dr. Novais. I appreciate it.